Welcome to the deep dive, everyone. If you're a resident right now, staring down your plastic surgery board exams, maybe you're prepping for the FRCS or, your local equivalent, you are in exactly the right place.
Absolutely. We're going to get straight into the mechanics of what you need to know, why you need to know it, and exactly how to synthesize it when you're in the hot seat across from an examiner.
Right, because we know your time is incredibly valuable.
Yeah.
So, really quickly, before we unpack today's material, if you're studying with us and you learn something today that, clarifies a difficult concept, please hit follow on the show and leave us a rating.
It really helps.
It does. And also, if you're serious about your board prep, you need to get a premium subscription. That is strictly where you'll get access to our journal club and our clinical cases deep dives.
Yeah, those are essential listening for the exams.
Definitely. So make sure you go sign up for that right now. All right, let's dive into today's topic: congenital deformities and synostosis of the upper limb.
It's a classic high-yield exam area.
It really is. And it's one where precision in your terminology and a spatial understanding of the underlying anatomy are absolutely critical. We're not doing a long setup today. We're just getting right into it.
Good. Because this is an area that separates the candidates who have simply, memorized lists from the candidates who actually understand the architectural engineering of the hand and forearm.
Right.
When you're sitting in a viva, the examiner is not just looking for a diagnosis. They're looking to see if you understand the biological forces driving that deformity.
So let's start with a very common presentation. Clinodactyly, we see this all the time. If an examiner asks you to define clinodactyly and describe exactly what you see when a patient walks into the clinic, what's the gold standard response?
Well, the word itself gives you the foundation, really.
Right.
Clinodactyly comes from the Greek, literally meaning inclined finger.
Okay.
Clinically, it's characterized by the curvature of a digit, specifically in the radio-ulnar plane.
So we're talking about a side-to-side curvature. Like, it's not bending forward toward the palm or, backward toward the back of the hand. It's deviating sideways.
That is the defining vector, exactly. And in a classic presentation, it most commonly affects the little finger. You'll see the little finger curving inward.
Right, so the fingertip is pointing directly toward the ring and middle fingers.
You've got it. That's the clinical picture. The little finger is hooked inward.
But here's where I want to push on the actual mechanism, because I know it involves the middle phalanx, but what exactly is going wrong at the bone level to cause that specific sweeping curvature?
The primary driver is a malformation of that middle phalanx. Instead of a normal rectangular bone that stacks neatly in the finger, you have what's called a delta phalanx.
A delta phalanx?
Yeah, it's a bone that has developed into a triangular or like a wedge-like shape.
So a triangular bone sitting where a rectangular block should be, that obviously throws off the entire vertical alignment of the joints above and below it.
Exactly, it cascades.
But why does the bone form that way in the first place? I mean, it doesn't just decide to be a triangle one day.
No, it comes down to a fundamental error in the epiphysis, the growth plate. In a normal phalanx, the growth plate is a transverse line at the base of the bone, right?
Yep.
Driving growth straight distally.
Right, like an engine pushing straight up.
Exactly. But in clinodactyly, the epiphysis is abnormal. It's J-shaped or C-shaped. It extends abnormally up onto the lateral side of the phalanx.
Oh, wow.
Yeah, we refer to this anatomically as a longitudinal bracketed epiphysis.
I want to make sure I'm visualizing this mechanical tethering correctly. So normally it pushes straight up, but here, this longitudinal bracketed epiphysis wraps around the side of the bone. So as it tries to grow, it's essentially locked on one side.
The longitudinal arm of that bracket acts as a tether, yes. Growth from that abnormal side is restricted, or at least altered, while the opposite normal side of the phalanx continues to grow at a regular pace.
I see.
So that differential in growth rates, one side growing faster and longer than the tethered side, it forces the bone to tilt over, creating that wedge shape and the resulting radioulnar curvature.
It's essentially structural tethering. The bone is bowing away from the side that's growing normally, curling around the restricted side.
That's a perfect way to visualize it.
Now, if we're in an exam,
Yeah.
we can't just talk about isolated finger anatomy.
Right.
We have to treat the patient as a whole. What syndromic associations do we need to have ready to deploy?
Clinodactyly is a feature in many syndromes, but the absolute high-yield statistic you must have loaded in your mind is its association with Down syndrome.
Okay, Down syndrome.
Yeah, clinodactyly is present in approximately 25% of all Down syndrome cases.
25%. That is a massive demographic.
It really is. You have to know that number.
Now, I was looking at Kirner's deformity in the notes earlier, and at first glance, it just looks like Clinodactyly to me. I mean, they're both bent fingers.
They do look similar initially, yeah.
So if a patient comes in with a curved pinky, why wouldn't I just diagnose Clinodactyly and treat them the same way? How does a resident confidently differentiate between the two under pressure?
Well, they might look vaguely similar to an untrained eye, but structurally and chronologically, they're completely different beasts. First, look at the anatomy.
Okay.
We said clinodactyly is a curvature of the middle phalanx in the radio-ulnar plane. Kirner's deformity, however, affects the distal phalanx, the tip of the finger.
So it's the bone one level up.
Yes. And the direction of the curve is entirely different. Kirner's is a progressive palmar radial curvature.
Palmar radial. So instead of just hooking flat to the side like a windshield wiper, which is what we see in Clinodactyly, the tip of the finger in Kirner's is bowing downward toward the palm and slightly inward.
Exactly.
It almost sounds like an eagle's talon forming at the tip of the finger.
That visual model works perfectly for distinguishing the two. The timeline is your other major diagnostic clue here.
How so?
Clinodactyly is a congenital issue. You see it early on because that bracketed epiphysis is present from birth, altering growth from day one. Kirner's deformity, however, develops much later, usually becoming apparent in adolescence.
Oh, okay.
And it can be an inherited trait or occur completely sporadically.
Now, what about the functional impact?
Right.
Because if a teenager comes into the clinic with Kirner's deformity, panicking about this sudden curvature at the tip of their finger,
Yeah.
are we rushing them to the operating room to straighten it out?
We are actively reassuring them and sending them home.
Really? Just sending them home?
The most critical thing to know about Kirner's deformity for your boards is that it almost never affects the mechanical function of the hand. It's primarily a cosmetic concern, and surgical intervention is rarely, if ever, indicated.
Right. So let's carry that philosophy over into the surgical management strategies for Clinodactyly.
Yeah.
Because with Clinodactyly, the vast majority of cases we see are also mild.
Very true.
When is surgical intervention actually justified? And more importantly, when do we do it?
You have to exercise extreme restraint here. For mild clinodactyly, surgery should be actively discouraged. The functional deficit is usually negligible.
So we're waiting for a severe case, basically.
Exactly. You only consider bringing the patient to the OR if the curvature is so severe that it physically limits their daily function, for example, if the fingers are crossing over each other when they try to make a fist.
Right. That makes sense.
And critically, if you decide surgery is necessary, you must delay it until the patient has reached skeletal maturity.
So only until skeletal maturity. We have to assume the examiners will test you on the why here.
Oh, they definitely will.
So if you operate on a child's active growth plate to try and straighten the finger early, you're introducing surgical scar tissue into a biological engine that's already functioning unpredictably.
Exactly.
You risk causing entirely new iatrogenic growth arrests and creating a deformity far worse than the original Clinodactyly.
You're trading a known stable curvature for an unpredictable growth arrest. You simply wait until the bones are entirely finished growing, the growth plates are fused, and then you step in to definitively straighten the static bone.
Okay, let's play this out. We have a patient, they're 18, they've reached skeletal maturity, and the Clinodactyly is severely limiting their ability to grip objects. We're going to operate.
All right, let's do it.
Let's think about the mechanics of the surgical osteotomies we use to straighten this out. If you have a misaligned door frame that's too short on one side, you don't chop the long side down, then the door won't fit at all. You wedge a shim under the short side to prop it up.
That's a great analogy.
Walk us through the biomechanics of how we fix the finger.
The foundational procedure is indeed a wedge osteotomy to correct the angulation, but your choice of wedge is paramount. We almost universally utilize an opening wedge osteotomy,
which acts just like that shim. But why are we so insistent on an opening wedge? Like, why not just cut a triangle out of the long side of the bone, close the gap, and put a pin in it?
Because you have to account for the overall architecture of the hand. In Clinodactyly, the affected finger is almost always already abnormally short.
Ah, right.
If you perform a closing wedge osteotomy where you remove bone stock from the convex, longer side, you're making an already short finger even shorter.
Which is bad.
Very bad. By doing an opening wedge, you make a transverse cut through the bone on the short concave side, and you physically lever it open to straighten the finger. This approach actually helps maintain or even slightly increase the overall length of the digit.
You're propping open the short side to match the long side. But if you prop it open, You've now created a physical void in the bone.
Hmm.
How do you fill that gap? Do we have to harvest bone graft from the hip or the wrist?
Harvesting from a distant site brings unnecessary morbidity. This is where we use a highly elegant surgical solution called the exchange wedge osteotomy.
The exchange wedge osteotomy. Okay, how does that work?
Well, you still need to correct the angle, right? So you excise a tiny wedge of bone from the longer convex side of the phalanx to help neutralize the curve. Then you take that exact piece of excised waist bone and insert it directly into the opening wedge gap you just created on the shorter side.
Oh, wow. You're solving two problems at once. You're correcting the severe angle on the long side, and you're utilizing that waist bone as a custom-fit biological shim for the short side, completely avoiding the need to harvest a graft from elsewhere.
It's a perfect conservation of mass. It achieves alignment while managing the bone stock autonomously within the finger.
That's brilliant. But the skeletal structure isn't the only tissue involved here. If a finger has been growing curved for 16 or 18 years, the skin, the fascia, and the neurovascular bundles on the short concave side are going to be chronically tight.
They absolutely are.
They've adapted to that short length. What are the soft tissue considerations when we suddenly lever this finger straight?
You cannot just force the bone straight and ignore the soft tissue envelope. That chronic tightness on the concave side will act as a massive tether, and if you force it, you risk compromising the blood supply to the finger.
So what do we do?
To address this soft tissue shortage, you must often incorporate Z-plasties or local flaps to recruit skin and release the tension, allowing the finger to straighten safely.
So all of this relies on waiting until the patient stops growing.
Yeah.
But is there any scenario where we directly address that abnormal bracketed growth plate itself before skeletal maturity? Are we entirely locked into waiting, or is there an early intervention strategy?
There is one notable exception to the wait until maturity rule, and it's a fascinating physiological approach described by Vickers.
The Vickers procedure.
Yes, Vickers' procedure involves the actual physical resection of that abnormal epiphyseal bracket.
You go in early and just cut the tether away.
You remove the abnormal bone bridge that is restricting the lateral growth, but the body's natural response to that surgical void will be to form scar tissue or new bone, which would just bridge the gap again and retether the growth plate.
Right, the body tries to heal itself.
Exactly. So Vickers described placing an interposition fat graft directly into the defect created by the resection.
So we're essentially stuffing a biological pillow into the growth plate to keep the bones from holding hands again.
That fat graft acts as a permanent physical barrier. It prevents the bony tether from reforming, which theoretically allows the remaining normal part of the epiphysis to continue growing properly without that lateral restraint pulling it into a curve.
Resection of the epiphyseal bracket with an interposition fat graft. The Vickers procedure. That is a fantastic high-yield concept to understand for the boards because it shows you understand the biology of the growth plate, not just carpentry.
Exactly. It's biology, not just mechanics.
Let's transition our thinking a bit. We've seen what happens when a joint grows asymmetrically. But what happens when the joint completely fails to separate in the first place? This brings us to symphylanism.
Right. A whole different issue.
Define this condition for the listener and give us the absolute key clinical signs they need to look for.
Symphylanism is the congenital fusion of one phalanx to another within the same digit. During normal embryological development, the continuous cartilaginous rods of the limb buds are supposed to cavitate and separate to form individual joint spaces.
Right.
In symphylanism, that separation process simply fails. The bones remain fused together. The classic clinical hallmark, the thing you must look for the second you inspect the patient's hand in an exam scenario, is the complete absence of flexion and extension creases over the affected joints.
When you're staring at an x-ray in your exam, the examiner is waiting for you to miss this. Because if there's no joint underneath, the finger never bends during fetal development. And if the finger never bends, those overlying skin creases never fold and form. It's a perfect correlation between surface anatomy and underlying embryological pathology. You have to actively hunt for those missing creases.
You really do.
When you notice them missing and you order the radiograph, what specific changes are we looking for?
On the X-ray, you'll notice that the middle phalanges are usually abnormally short. But crucially, you'll see poorly developed joints and epiphyses. The space where you expect to see a crisp, dark, clear joint line will look blurred, bridged by bone, or severely underdeveloped.
And just like with Clinodactyly, we need to know the conditions this pathology clusters with. What are the associated syndromes commonly appearing alongside symphylanism?
It's highly associated with several major conditions. You should immediately think of syndactyly, Apert syndrome, Poland syndrome, and radial longitudinal deficiency.
It makes sense that they cluster together. All of those syndromes involve disruptions during the critical 4th to 8th weeks of gestation, when the limb buds are differentiating, fingers are separating, and joints are supposed to be cavitating.
Exactly right.
If a patient presents with Aperts or Polands, you must have a high index of suspicion and actively look for that fused joint. So how does the treatment algorithm for symphalangism compare to what we just discussed for clinodactyly? Are we jumping in early to try and carve out a new joint?
Attempting to surgically engineer a new functional joint out of a solid bone block in a child is almost uniformly unsuccessful.
So it's similar to clinodactyly then.
Very similar. You start with conservative management. Physiotherapy and splintage are the mainstays of early treatment to maximize whatever minimal function or position might be available from the surrounding joints.
Okay, and surgery.
Definitive surgical options, which in this case would be an osteotomy to change the angle of the fused finger, or a formal arthrodesis to fuse it in a more functional position, are strictly reserved until the patient is skeletally mature.
Wait for skeletal maturity. It is the dominant theme of hand deformities. You don't mess with the complex growth patterns of the hand until the hand is done growing, unless you're deploying a very specific targeted intervention like the Vickers procedure.
That's the golden rule.
Now let's zoom out from the individual digits and look at the entire upper limb. We've talked about a crooked finger, we've talked about a fused joint inside a single digit. Now we're talking about massive structural fusions across the forearm and wrist. Synostosis.
Let's do it.
Classify synostosis for us, and let's figure out which ones actually require a surgeon's attention.
Synostosis is defined broadly as the abnormal fusion of any two adjacent bones. It can occur at literally any site where two bones sit next to each other.
Right.
For example, synostosis between adjacent phalanges is the defining hallmark of complex syndactyly. Moving proximally, you can have carpometacarpal, intercarpal, and radiocarpal synostosis within the complex architecture of the wrist.
But when we look at those wrist fusions, are we routinely taking patients to the OR to drill out an intercarpal synostosis?
Very rarely. Carpometacarpal, intercarpal, and radiocarpal synostosis seldom cause a functional deficit severe enough to justify the risks of surgery.
The rest of the hand just sort of adapts.
Yeah, the surrounding joints in the wrist and hand usually adapt quite well to compensate for those localized fusions.
But there is one major exception, and this is the one the examiners will absolutely drill you on. Radioulnar synostosis. The fusion of the radius and the ulna in the forearm. If this fusion is bilateral, if both arms are locked, the functional devastation must be profound.
It is a life-altering impairment. The radius and ulna need to rotate seamlessly around each other for you to pronate and supinate your forearm to turn your palm up to the sky and down to the floor.
Right, basic movements.
If those two bones are fused together into a single block, that rotation is entirely eliminated. If it happens in both forearms simultaneously, the child cannot easily bring food to their mouth, they can't accept change from a cashier, they struggle to dress themselves, and they struggle with basic hygiene.
So for bilateral radioulnar synostosis, waiting for skeletal maturity and watching them struggle for 18 years is simply not an option. What is the specific surgical strategy here, and what is the timing?
You cannot restore the dynamic rotation. What you can do is reposition the static block. The treatment is a rotational osteotomy straight through the synostosis.
Okay, so you just cut through it.
You surgically cut through the fused bone mass, physically rotate the arm into a more functional, predetermined position, and let the bone heal back together in that new alignment. And crucially, unlike the digital deformities we discussed, you perform this much earlier, typically around 5 years of age.
5 years old. That is a massive structural departure from the wait for skeletal maturity rule we leaned on for clinodactyly in symphylanism.
It is, and the driving force behind that decision is functional development. You cannot leave a child locked out of basic daily activities during their most critical formative years.
Yeah, that makes sense.
You have to intervene early to allow them to develop independence and interact with their environment before the psychological and physical deficits become permanent.
Okay, so you cut the fusion at age 5. But you aren't recreating a moving joint. You're just locking the forearm into a new permanent position. What are the exact degrees of fixation required for each limb? Because if they can't rotate either arm, you certainly don't want to put both arms in the exact same static position.
That is the pivotal concept, and it is a classic board question. You must position them asymmetrically to maximize their combined function. The aim is to fix the dominant limb in 10 to 20 degrees of pronation.
Dominant limb, 10 to 20 degrees of pronation. So the palm is angled slightly downward. Why that specific angle?
Because that is the optimal anatomical angle for writing on a desk, for typing, and for the dominant role in many aspects of bimanual manipulation, like holding a tool.
Got it. And for the other side?
Now, for the non-dominant limb, you fix it in a mid-prone position, essentially a neutral handshake position with the thumb pointing up.
Mid-prone for the non-dominant arm. Think about how profoundly simple mechanical angles dictate human dignity. What does that specific combination of 10 to 20 degrees pronation on one side and neutral mid-prone on the other actually unlock for this child?
It unlocks their ability to navigate the world independently. That specific alignment allows for eating. They can bring a utensil to the mouth smoothly. It allows for writing.
Right.
It facilitates complex bimanual manipulation, like buttoning a shirt or stabilizing a piece of paper with the mid-prone hand while writing with the pronated hand. And perhaps most importantly for their dignity and independence, it allows for proper perineal care.
Basic bathroom hygiene. If both arms were locked in full pronation or full supination, they wouldn't be able to reach properly to clean themselves. It's a brilliant mechanical compromise. You sacrifice the dynamic rotation entirely, but by carefully selecting two distinct complementary static angles, you give them back their ability to care for themselves.
It perfectly highlights the core guiding principle of upper limb reconstructive surgery. Form must follow function. We're not operating to make the X-ray look normal. We are engineering a mechanical setup that allows the patient to live a functional life.
This has been an incredibly high-yield session. We've covered the mechanical tethering of the delta phalanx in Clinodactyly, the embryological failure behind the absent creases in symphalangism, and the precise asymmetrical rotational fixations for radio-ulnar synostosis. To wrap this up, I want to leave you, the listener, with a final thought to mull over as you organize your notes for the exam.
What's the thought?
Look at the striking contrast in surgical timing, based entirely on the functional milestones of the patient.
It's the unifying theme of everything we've discussed today.
Exactly. For clinodactyly and symphalangism, we have the luxury of time. We wait for skeletal maturity because the functional deficits are usually manageable, and preserving the delicate, normal growth patterns of the hand is the absolute priority.
But then you look at bilateral radio-ulnar synostosis.
Right. The loss of that rotational axis is so debilitating to a child's early development that it forces our hand. We intervene at age 5, cutting right through the synostosis, to prioritize critical developmental milestones like feeding and bimanual manipulation. It's a perfect reminder that clinical decision-making isn't just about evaluating the bone. It is about evaluating the patient's stage of life.
Grasping that underlying why behind the timing is exactly what transforms a safe, average exam answer into an outstanding one.
All right, that is all for this revision session. If you are deep in the trenches studying these topics right now, we want to hear from you. Leave us a comment or a question about today's material. What is the one mechanical concept you're still trying to visualize or wrap your head around? Drop it in the comments below, and we will keep the conversation going. Keep studying hard, trust your preparation, and we will see you on the next Deep Dive.